Hello guys, so let's discuss about medium vessel vasculitis. So as you know, there are two important diseases in medium vessel vasculitis, namely Kawasaki disease and polyarteritis nodosa. So moving on with the Kawasaki disease it is also known as mucocutaneous lymph node syndrome. Okay, mucocutaneous lymph node syndrome. Kawasaki disease mainly affects medium to small arteries and it has a predilection for coronary artery. Now, Kawasaki disease, it is the commonest cause of acquired heart disease in children in developed countries. And the incidence of coronary artery aneurysm, initially it was 25%, but now it has been dropped to 4%. So the incidence is reduced due to timely initiation of treatment with IVIG. So epidemiology, the Kawasaki disease is usually found in less than 5 years of age, more commonly in Asian children and mostly of Japanese ancestry. So the reported cases is 25 per 1 lakh per year and male is to female ratio is 1.5 is to 1. Now there are certain single nucleotide polymorphism in genome-wide association studies which are noted, namely caspase-3, HLA class 2, inositol, 145 ITPKC, that is 145 triphosphate kinase C, FC, gamma R2A, BLK, B cell lymphocyte kinase, and CD40. And if it has a TGF beta variant, then it is associated with increased risk of aneurysm formation. So, moving on to the pathophysiology, what happens that initially there is activation of innate immune system, which will lead to will lead to recruitment of neutrophils. Now, the activation of neutrophils, it will again activate your interleukin 1, interleukin 6, and TNF signaling pathways. And due to these pathways, after the fever onset, there will be both pro-inflammatory and T-regulatory cells circulate in the blood during the first week. So during this period where the pro-inflammatory cells are circulated in the blood, the patient will develop fever. Okay, so after we administer IVIG, there is expansion of T regulatory cell population. Okay, and then it will lead to cessation of fever and clinical improvement. So thus the disease is self-limited and there is low rate of recurrence. As we know, there is emergence of T and B memory cells which protects against future encounters of Kawasaki disease. So T and B memory cells are the memory cells. Yes, so due to this, there is no recurrence and the patient would have protection against future encounters of Kawasaki disease. So moving on to the pathology, the characteristically Kawasaki disease involve medium-sized arteries, but it can involve both small and large size blood vessel. So what happens basically the three interlinked processes, that is firstly there will be necrotizing arteritis which will lead to subacute to chronic vasculitis, and there will be luminal myofibroblastic proliferation LMP. Okay, so necrotizing arteritis which will lead to vasculitis, subacute or chronic vasculitis, and LMP, luminal myofibroblastic proliferation. Necrotizing arteritis, subacute to chronic vasculitis, luminal myofibroblastic proliferation. Now, due to these inflammatory processes, there will be destruction of internal and external elastic lamina. Okay, so when the internal and external elastic lamina is destroyed, there will be aneurysm formation. Due to aneurysm formation, there can be thrombosis. Okay, so if there could be large aneurysm or there can be a small aneurysm. So what are large aneurysm? Large aneurysm are aneurysm who are more than 8 mm in diameter or more than equal to 10 z square. Now these large aneurysm, they will not resolve or regress or remodel. Now these large aneurysm will be a house for thrombi. They will contain thrombi. Thrombi will eventually cause undergo calcification, which will cause occlusion. Okay, or there are certain aneurysms where there is markedly damaged but partially preserved media. So media may you have muscles, so there will be stenosis, the contraction of muscles which will lead to stenosis of the arteries. So either there would be occlusion or there would be stenosis of arteries, medium arteries. Now, there could also be subacute to chronic inflammation, which would be around coronary arteries. So, which will lead to pericarditis and myocarditis. Here, it is important that in histopathology, you get damage to internal and external elastic lamina. Okay. Now, about the clinical features, there are 4 phases, namely the acute febrile stage, where you would have your fever and other symptoms. You have subacute phase, which is marked characteristic is desquamation. Then you have your convalescent phase and chronic phase. Now, acute phase, it lasts approximately for 2 weeks, 1 to 2 weeks, so 7 to 14 days, and there will be abrupt onset. Okay, So the hallmark, so the most characteristic feature is fever. Fever would be in Kawasaki, it will be high spiking, that is 1022 to 104 degree Fahrenheit or 39 to 40 degrees Celsius or more than that. So high spiking, peak temperature and remittent fever will be seen in Kawasaki disease, and it will not respond to any antibiotics or antipyretics. So what is the treatment here? We will give IVIG. Intravenous immunoglobulin is given at a dose of 2 gram per kg per day. After giving IVIG, the fever would come down typically within 36 hours. If the fever does not come down within 36 hours, we can consider a second dose of IVIG and alternate therapy. Alternate therapy could be steroid sparing agents like methotrexate, azathioprine, or certain biologics. So, along with fever, there can be erythematous rash, bilateral bulbar non-exudative conjunctival injection, lips oral cavity involvement, and cervical lymphadenopathy. So, erythematous rash will develop within 5 days. It would be most commonly a diffuse maculopapular rash. Okay. But there could be another type of rash like scarletiniform rash like or erythroderma or EM like eruption, urticarial or fine micropustular rash. Most commonly, we will get to see diffuse maculopapular rash, and there will be extensive involvement of trunk and extremities, and there will be accentuation in groin. So in groin, you get to see early desquamation. So this use of fever and rash. Then patient would get bilateral bulbar non-exudative conjunctival injection. Yes, it will be non-exudative, and it will often spares limbus. On slit lamp examination, you will get anterior uveitis, subconjunctival hemorrhage, or punctate keratitis. Now, lips and oral cavity, there could be erythema, dryness, peeling, fissuring, cracking, and bleeding of lips. There could be strawberry tongue due to erythema with prominent fungiform papilla, and there will be diffuse erythema of oropharyngeal mucosa. Now, cervical lymphadenopathy, it is the least commonly seen principal clinical features. There will be unilateral lymph node swelling more than equal to 1.5 centimeter in anterior cervical triangle. So, that would be unilateral cervical lymphadenopathy. Lymph node would be swollen more than 1.5 centimeter in anterior cervical triangle. Now, other features we could get is like aseptic meningitis, otitis media, myocarditis. Sorry for the other features you could get would be aseptic meningitis, otitis media, myocarditis, pericarditis, pneumonitis, or hepatic renal GI dysfunction, hydrops of gallbladder, sterile pyuria, orchitis could be there. Okay, orchitis, it could mimic a testicular torsion in Kawasaki disease. Orchitis, you will also get to see testicular torsion. Testicular pain, you will get to see also in polyarteritis nodosa. Then meatitis, pulvitis, urethritis, and BCG site reactivation. So this would be acute phase, which will last for 7 to 14 days, like 2 weeks. So subacute phase, when the fever has gone down, when the fever is abated. So week 4 to 6, you will get your subacute phase. So it begins with desquamation. So 2 to 3 weeks after the fever onset, there would be desquamation, which will begin initially in the periungual region, which will extend to involve palm, soles, and perineal region. There will be flare of fresh onset atopic dermatitis. There can be flare of fresh onset atopic dermatitis in subacute phase, and there would also be thrombocytosis, which would be more than 1 million per microliter, or there could be development of coronary artery aneurysm, and in this case, the patient has a high risk of sudden death. In 20 to 40% of cases in the subacute phase, they get arthralgia arthritis, which will favor the large weight bearing joints. And there would be persistent irritability, anorexia, conjunctival injection. So the patient of Kawasaki is usually sick baby. Then convalescent phase within 3 months of presentation. So now in convalescent phase, there is resolution of clinical signs. There is return to baseline of acute phase reactants like your ESR, your CRP, your platelet count. Everything will return to the baseline. There can be Bewes lines. Bewes lines are horizontal ridging over the nails, which occurs within 1 to 2 months of fever. Then cardiac abnormalities, there could be smaller coronary artery aneurysm. So the smaller coronary artery aneurysm could resolve on their own, but the large aneurysm which may expand, there could also be thrombosis, stenosis, occlusion. And new aneurysm are unusual after week 8 of illness. Now, chronic phases in the patient who has developed a cardiac complication, and it may last a lifetime. As the aneurysm which is already formed in the childhood, it can rupture anytime in the adulthood. So that's why the chronic phase lasts a lifetime. Now, systemic manifestation of Kawasaki disease. Cardiovascular manifestation, you can get myocarditis, pericarditis, valvular regurgitation, shock, coronary artery anomalies. There could be aneurysm of medium sized non coronary arteries, peripheral gangrene, aortic root involvement, enlargement. In respiratory, you can get peribronchial and interstitial infiltrates on chest x ray with pulmonary nodules. Musculoskeletal, there could be arthritis, arthralgia due to pleocytosis of synovial fluid. Genitourinary complications include urethritis, meningitis, hydrocele. In gastrointestinal symptoms, you will get diarrhea, vomiting, abdominal pain, hepatitis, jaundice, hydrops of the gallbladder, pancreatitis. Nervous system involvement, the patient may get extreme irritability, a septic meningitis, or facial nerve palsy, sensory neural hearing loss. Then others you can get desquamating rash in groins, retropharyngeal phlegmon, anterior uveitis by slit lamp examination, and erythema and induration at BCG site. Now, regarding the cardiovascular involvement, it is very important in the patient of Kawasaki disease. So, the pericardium, myocardium, endocardium, valves, and coronary arteries, basically all the structure of heart, all may become inflamed. So what happens in the acute phase? There is a hyperdynamic precordium, that is hypervolumic precordium with tachycardia. So when there is a hyperdynamic precordium, you will get accentuation of innocent systolic flow murmurs. Okay. And valvular dysfunction is seen in nearly 25% of the patients, which is often mitral valve dysfunction. And there could be, if it is associated with mitral regurgitation, the patient may have a pansystolic murmur. And Kawasaki disease shock syndrome is also noted in children who have systolic hypotension. So in this we saw there could be hyperdynamic precordium with tachycardia, which will lead to accentuation of innocent systolic flow murmurs. And KD syndrome is also seen in children who have systolic hypotension. KD shock syndrome. Now the patient, you will get valvular dysfunction in 25% of the patient, namely mitral valve, mainly mitral valve, and in cases of MR, the patient can have pansystolic murmur. Now, coronary artery aneurysm are the most characteristic and clinically important finding. It occurs in 15 to 25% of untreated patients. Now, giant coronary artery aneurysm that are more than 8 mm in internal diameter, they have a high risk of thrombosis and rupture. Yes, Z score of more than 10 and more than 8 mm internal diameter. These are called giant coronary artery aneurysm. They do not resolve, or they do not regress, or they do not remodel on their own, and it has a high risk of thrombosis and rupture. Also, there could be stenosis. Due to stenosis, there could be ischemia in adults. So, moving on to diagnosis of Kawasaki disease. So, classic Kawasaki disease is diagnosed in the presence of fever for at least 5 days. The day of fever onset is taken as to be the first day of fever. So, you should have at least 5 days ka fever with at least 4 of the 5 following principal criteria. What is the clinical features? There could be erythema with cracking of lips, strawberry tongue, and erythema of oral and pharyngeal mucosa. So lips, tongue, oral and pharyngeal mucosa, erythema. Then there could be bilateral bulbar conjunctival injection without exudates. There could be rash, which could be maculopapular or erythroderma or EM-like or scarlet uniform. So rash. Then there could be erythema and edema of the hands and feet in acute phase and periungual desquamation in subacute phase. And there could be cervical lymphadenopathy, unilateral mostly, and more than equal to 1.5 centimeter in diameter. Again, there could be, firstly, so you need fever more than 5 days. After fever more than 5 days, you need erythema. Firstly, तो eyes सबसे ऊपर है. So bilateral bulbar conjunctival injection without exudate. That is non-purulent bilateral bulbar conjunctivitis. Then erythema with cracking of lips, strawberry tongue, erythema of oral and pharyngeal mucosa, like your lips, tongue, oral and pharyngeal mucosa, erythema, it should be there. Then there could be a cervical lymphadenopathy, which is more than equal to 1.5 centimeter, usually unilateral. Then there could be rash on your body, which could be maculopapular or erythroderma or EM-like rash. And there could be erythema and edema of the hands and feet in acute phase or periungual desquamation in the chronic phase. These are the 5 points. You need at least 4 out of 5 and fever of 5 days for the Kawasaki disease diagnosis. But sometimes what happens, more than equal to in the presence of more than equal to 4 principal clinical features, particularly when redness and swelling of the hands and feet are present, the diagnosis of Kawasaki disease can be made with 4 days of fever. Although experienced clinicians who have treated many patients with KD may establish the diagnosis with 3 days of fever in rare cases. So you do not have to wait for 5 days to make the diagnosis of Kawasaki disease, as it has a risk of coronary artery aneurysm and lifelong cardiac abnormalities, right? So even if you have more than equal to 4 principal clinical criteria present and the fever is more than 4 days, and still you can make a diagnosis of Kawasaki disease. Or some experienced clinician would be there who would make it with 3 days of fever. If a patient has fever and sterile pyuria, always suspect Kawasaki disease. Now, investigation, so there would be non-specific markers of inflammation. So there would be raised ESR, raised CRP, raised transaminase level for inflammation. Then leukocytosis would be there with neutrophil predominance. There could be thrombocytosis, that is 10 lakh per mm cube, and there would be normocytic normochromic anemia. Now, macrophage activation syndrome is there in suspected in case of anemia with thrombocytopenia. Now, sterile urethral pyuria can also occur in Kawasaki disease. If there is a pyuria in a febrile child, you have to consider Kawasaki disease, and patient may get increased level of triglyceride and reduced level of LDL. So these are the markers of inflammation. Okay, ESR, CRP, AST, ALT, TLC, neutrophil, thrombocytes, the inflammatory markers. Now, imaging. So two-dimensional transthoracic echocardiography. Okay, two-dimensional around the thorax echo. So two-dimensional transthoracic echocardiography has to be done for the assessment of coronary artery aneurysm. Now, when would you say that there is a coronary artery aneurysm? Dilated coronary artery per se. There would be diameter of more than 1.5 centimeter than the adjacent vessel, or the diameter would be more than 3 mm in a child less than 5 years, or more than 4 mm in a child more than 5 years. Okay. So diameter should be more than like 1.5 times that of the adjacent vessel, then more than 3 mm, more than 3 mm in a child less than 5 years, more than 4 mm in a child more than 5 years. Then it is said to be a dilated coronary artery. Now, echo has to be repeated within 1 to 2 weeks or 4 to 6 weeks after the treatment. If it is an uncomplicated patient, then 1 to 2 weeks or 4 to 6 weeks you would repeat the echo. But if there is evolving coronary artery abnormalities or Z score more than 2.5, you will have to up the frequency of your echo. Okay. So this we have seen. Also, giant aneurysm are more than 8 mm and Z score more than 10. Okay. Now, how will you evaluate? So, firstly, there will be a children more than equal to 5 days and 2 or 3 compatible clinical criteria, or infants with fever more than 7 days without other explanation. And also, there could be incomplete Kawasaki disease, where there would be presence of criterias, 4 or 5 criterias, but fever could be more than 4 days or 3 days. So, what are the criteria? Once again, there could be bilateral bulbar non-purulent conjunctivitis. There could be erythema with cracking, fissuring, peeling or bleeding of lips. There could be strawberry tongue. There could be oral and pharyngeal erythema. There could be unilateral cervical lymphadenopathy, which is more than 1.5 centimeter. It is usually unilateral. Then there could be maculopapular rash or other type of rash, rare like scarlet uniform rash, erythroderma or EM-like rash. Then there could be erythema and edema of palms and soles in the acute stage, or periungual desquamation in the chronic stage. So these are the criteria. Now, what will you do after this? You will assess the laboratory test. If the CRP is less than 3 and ESR is less than 40 mm per hour, that is, the inflammation has not much occurred, then you will do serial clinical and lab evaluation if the fever persists, and you will do echocardiogram if typical peeling develops under nail beds, which is the acute, subacute stage. And if it happens, you will treat the patient as Kawasaki disease. If the CRP is more than 3 and ESR is more than 40, then you will assess for other lab findings. The patient could have normocytic normochromic anemia. The platelet count, there could be thrombocytosis, which could be more than equal to 4,50,000 after the 7 day of fever. Albumin could be less than equal to 3 gram per DL. Elevated ALT, WBC count of more than 15,000 per mm cube. And urine more than equal to 10 WBC per high power field, or there could be a positive echo. Then you will first do serial clinical and lab re-evaluation and echocardiography and treat the patient. Okay. So how will you evaluate? So consultation with an expert should be sought anytime assistance is needed. So clinical findings are listed above. Characteristics suggesting that an alternative diagnosis should be considered. So exudative conjunctivitis, pharyngitis, ulcerative intraoral lesion, bullous or vesicular rash, generalized lymphadenopathy or splenomegaly. In all this condition, you will consider an alternative diagnosis instead of Kawasaki disease. If infants are less than 6 months of age, which are most likely to develop prolonged fever, having no other clinical criteria for Kawasaki, and they are particularly at high risk for developing coronary artery abnormalities. So then you will evaluate for Kawasaki. Echocardiography is considered positive if any of the three conditions are met. So echo is positive when Z score of the left anterior descending coronary artery or right coronary artery is more than equal to 2.5, or the coronary artery aneurysm is present, or more than equal to three other suggestive features coexist, including decreased left ventricular function, pericardial effusion, mitral regurgitation, or Z score in the left anterior descending artery or right coronary artery 2 to 2.5. So, if the echo is positive, treatment should be administered within 10 days of the onset of the fever or after the 10th day of the fever, in the presence of clinical and lab signs. Okay, so once again we would see how when the echo is positive, right? Echo is considered positive, so the patient has to meet three conditions on echocardiography. So Z score of left anterior descending artery or right coronary artery, LAD or RCA, should be more than equal to 2.5, or there could be presence of coronary artery aneurysm, or other three features. So there could be decreased left ventricular function, or pericardial effusion, or mitral regurgitation. Okay, Z score of LAD and RCA should be more than equal to 2.5. Z score should be more than equal to 2.5. Coronary artery aneurysm if present, or there could be more than equal to 3, that is reduced left ventricular function, mitral regurgitation, and pericardial effusion. Okay, this should be present, or if the Z score is between 2 to 2.5. Okay, and if the echo is positive, we have to administer treatment within 10 days of onset of the fever, or after 10th day also treatment could be observed or could be administered if there is presence of clinical and lab sign. Okay, so what are the differential diagnosis of Kawasaki? So we have rash, that is maculopapular rash or scarlet uniform or erythroderma or EM like. So pertaining to this, you could suspect measles, viral infection like enterovirus, adenovirus, drug hypersensitivity syndrome like Steven Johnson syndrome, or the staphylococcal and streptococcal toxin mediated syndrome like scarlet fever or toxic shock syndrome, or there could be systemic onset juvenile idiopathic arthritis, Rocky Mountain spotted fever, or other rickettsial infection or leptospirosis. So, treatment. Main aim of treatment is to reduce the inflammation and reduce risk of coronary thrombosis. Okay, and you have to prevent myocardial ischemia who develop aneurysm or dilatation. If the aneurysm or dilatation has already been developed, then you have to prevent myocardial ischemia, and you have to reduce the risk of coronary thrombosis also. So slow infusion of IVIG is the main modality. You have to give slow infusion to prevent infusion reaction. So the dose is 2 gram per kg and it has to be administered within 10 days of illness. But if the patient presents late and it still have clinical and laboratory features, then IVIG can still be given. 2 gram per kg and we get to see immediate response. So usually the fever of Kawasaki will not respond with antibiotics and antipyretics, but after IVIG there would be immediate response. There would be subsidizing fever before end of the infusion, and there would be reduced irritability. Okay, and aspirin, we have to give the anti-inflammatory dose of aspirin, which is 30 to 50 mg per kg per day. Some books suggest 100 mg per day. We are giving here 30 to 50 mg per kg per day, and it has to be continued for 48 to 72 hours after the fever subsides. And then we will move on to, which is after 2 to 3 days, 3 to 5 mg per kg per day, and this aspirin dose has to be maintained till the child has no evidence of coronary artery abnormality by 6 to 8 weeks, till you have to maintain this dose. And if there is persistent aneurysm, then the aspirin dose has to be maintained indefinitely to prevent thrombosis and ischemia. So, in 10 to 15% of the patient, the fever does not subside or recur with IVIG. In this case, we will consider a repeat IVIG, and there could be infliximab like TNF alpha inhibitor, which is the alternative therapy with methylprednisolone. Okay, so repeat IVIG, infliximab, and MB methylprednisolone. And what if the patient is IVIG resistant Kawasaki disease? So what we give most frequently, we give IVIG second infusion, which is pooled polyclonal immunoglobulin at the dose of 2 gram per kg. Or we could give IVIG plus prednisolone or infliximab. So IVIG plus prednisolone, and we will give as usual IVIG 2 gram per kg IV, and prednisolone has to be given high dose 2 mg per kg per day, divided every 8 hourly until febrile. Then the prednisolone orally until CRP normalizes, and then we have to taper the steroid over 2 to 3 weeks. Or we could consider infliximab. Infliximab is a monoclonal antibody against TNF alpha. You have to give single infusion, which is 5 mg per kg IV, is given over 2 hours. Over 2 hours single infusion of infliximab. Okay. Now there are a certain alternative treatment like cyclosporine, anakinra, cyclophosphamide, and plasma exchange. Cyclosporine is the inhibitor of calcineurin NFAT pathway. It is given IV at a dose of 3 mg per kg per day, divided every 12 hourly, followed by per orally 4 to 8 mg per kg per day. Then anakinra is interleukin 1 recombinant interleukin 1. It is given in the dose of 2 to 6 mg per kg per day by subcutaneous injection. Cyclophosphamide, alkylating agent which blocks DNA replication. It has to be given 2 mg per kg per day IV, and plasma exchanges, that is we replace plasma with albumin. So that's it for your Kawasaki disease. Thank you.